So as doctors, I think sometimes we don't even think about the impact of the questions we ask in the order, right? I think it's those types of things. If you're a patient and you're holding on to some kind of belief structure because of a question someone asked you, make sure you ask someone else about it. I was very grateful that this patient was like, this feels like a really awkward question. But one time the doctor asked me if it was because of sex, like, is sex causing this? Because I'm almost afraid to have sex now. And I was like, absolutely not. Thank you for asking. Let's navigate this, et cetera, et cetera. So I think that's just a good tip for any patients out there feeling.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast.
Hello, everyone, and welcome to this week's episode of the Advanced Women's Health Podcast. I am really excited to give you guys a different perspective on our team. So one of the things a lot of people don't know is that our teams meet every day for clinical rounds. And so in those rounds, we talk about cases, we talk about things we want a different perspective on, we talk about things to challenge our perspective, even if we think we know what we're going to do, and we talk about things if we just want someone else in the room's expertise. And so because it's such a fun aspect of how we treat, I decided to take one of our lunch hour calls and pull two of our docs, Laura and Dasha, into the call. And we're going to talk about what we treated this week. Because as practitioners at Advanced Women's Health, we treat a lot of different things. We get asked, so our patient onboarding coordinator is constantly like, people still ask, do you treat PCOS? Do you treat hair loss? Do you treat this? And because it is sometimes hard to understand that we have so many doctors who can treat so many different things so well. And so I am really just excited to dive in and kick this off with what we saw this week. So I will start. One of the things that I have seen a lot this week, and I know Laura's going to talk about labs and investigations in a minute as well, but one of the big things that's been coming up is we're headed into the school year. We're headed into like new January. September is my favorite January. It's like the beginning of a fresh start. And a lot of people are looking at what they've got done this year and what they haven't. And so I've been having a ton of conversations about adult female ADHD, what it is, how it shows up, where people are struggling, and when they're coming in, often asking, is a stimulant the right option for me? Is it not? And oftentimes this actually, I had this twice in the last week, having patients who took a stimulant and felt awful. Insomnia, bowel changes, headaches, severe anxiety. So I would love to know for you guys, is this something you're seeing a lot in practice? Like, how is it showing up? Give me a rundown.
Yeah, absolutely. I actually talked to a patient yesterday who was struggling with the same sort of thing, diagnosed with ADHD when she was younger, but didn't really do anything about it. And now she's kind of like mid-30s, runs her own business, and she feels the pressure and those symptoms are getting worse, right? Because she's also not necessarily doing what we call the foundations to help support herself. And she did actually exactly what you said. She took a stimulant, smaller dose, didn't really feel much. Higher dose, had the worst exacerbation of her anxiety, insomnia. She couldn't eat. Well, she at first didn't even realize that it was taking appetite away, right? So in ADHD patients that are on these stimulants, just the importance of educating around meal times and things like that, because that's also when our blood sugar gets wonky too, right? And I think we were discussing this during one of our calls this week, that in a lot of times with patients, they will get this crash when the medication is kind of tapering down in the evening, and they'll all of a sudden get like really tired, mood swings, things like that. So huge connection there for her.
Also eat like crazy.
Yes.
right? Like then we see nighttime eating, almost like binge eating behaviors. They don't know why they're so desperately wanting to eat all the carbohydrates at night. And then it gets them in this nasty cycle of blood sugar dysregulation, poor sleep, and
Exactly.
reemerge.
And it impacts sleep totally. Yeah. What we did with her is we switched her on a medication. It was a non-stimulant one, atomoxetine, and to see if that would help, because at this point she was kind of like desperate to try something else. But there's also like lots of other things from more of the naturopathic perspective that we can work on as well, if you want to touch on those, Sarah.
Yeah. Yeah. So when it comes to adult female ADHD, one of the first things I ask patients is, did you experience these symptoms prior to the age of 12, 15 in girls? Did you experience procrastination? Did you experience like overwhelm, trouble getting started? Because it doesn't often appear as hyperactivity, right? It appears in these very subtle symptoms. It's funny because girls and boys are so different in school. I have two boys. I am very mindful of like gender conversations in school systems. I won't start there. But historically, ADHD genes, like a lot of times it's the entrepreneurs, it's the people who have big thoughts, big ideas, who are pushing outside the box. And so for a lot of girls, they have those thoughts and feelings, but societally, they're very suppressed. They don't allow themselves to think outside the box. They don't allow themselves to push boundaries and barriers. When it comes to that diagnostic criteria, I resonate. But it's those types of patterns are oftentimes very much societally suppressed. And so we have to ask a lot of questions outside of just, did you experience this when you were younger? Because some of the things we know for sure when it comes to adult female ADHD is that blood sugar dysregulation and insulin, we just talked about that. When we look at inflammation and how what we call neurotransmitters, the chemicals in the brain are working, inflammation dramatically impacts the reward centers of the brain, the like get up and go initiation centers of the brain. So we know that histamine can do that. We know that a variety of other inflammatory compounds can do that. So we've got blood sugar, we've got inflammation, and then we have hormones. And between the ages of 37 and 42, I like can't wait to do this research study. But I think between 35 and 40 is where the majority of these diagnoses are occurring, because we don't necessarily see huge shifts in total hormone volume. We see volatility. And so when I ask patients, okay, did this symptom come on its own? Like, did you just develop the struggle with executive function, decision making, focus, all of these things? Did that come on its own? Or did it come with migraines before your period, with worsening PMS, right? With heavier menstrual cycles or pain with ovulation or spotting? And I would tell you 9 times out of 10, there's at least some of those other symptoms that are involved. And so as much as stimulants, non-stimulants, pharmaceuticals can be helpful, it's really those three things. What do we need to do to personalize your diet, which we'll talk about labs more coming up? What do we need to do to lower your systemic inflammation? Are you getting hives? Are you getting brain fog? Are you getting allergies? Laura and I were talking about allergies before this call, right? Like, are you getting allergic responses to things? Are you having more bloating and digestive issues? Are you having skin issues pop up? Are you having joint pain? Well, we need to address that. And a stimulant's not going to do that. And do we know what's happening with your hormones day to day? We have the technology now that you could test your hormones every day of the month at home if you want to. And we can get a sense of what's going on to then understand, do we need to put an estrogen patch on your arms, right? What does that look like to get you through some of those rapid fluctuations in the second half of your cycle? So yeah, that's been a huge conversation in my office at the moment.
Yeah, and I think it's been a big one in mine too, where I have lots of women reading about ADHD online, and then they come into our office and they say, I think I might have it, right? And we kind of have to ask a lot more questions about, well, what are the symptoms you're experiencing? And then talking through all of those main causes, like you just spoke about, Sarah, in terms of what can be contributing to their symptoms, right? And sometimes, yes, it's medication that they might need. And sometimes it's no, it's working on the insulin and the blood sugar. It's the inflammation. It's also, I think, looking at nutrient status and thyroid health, because those are some big ones too. that I see pop up that can contribute to the brain fog, the troubles concentrating, and things like that as well.
Absolutely. Okay. Well, Dasha, I know you've got a busy patient day, so we're going to get you to sneak in next so that Laura and I can round it out on our own if we need to. What are some of the things that have come up for you this week?
Yeah, so lots of skin stuff this week. Probably the most interesting case I saw was a male, mid-30s, and he has hidradenitis suppurativa. For those of you who don't know, which
is a lot of people.
Yeah, which is a lot of people. It's a crazy thing. Whenever I say it, people are like, what is that? But anyways, I'll refer to it as HS from now on, but it's a chronic inflammatory disease of the hair follicle. It can occur in the axilla, so the underarms, the groin, inframammary areas, which is a fancy way of saying kind of the breast fold area, and then the buttocks. There's different stages to it, but sometimes it can appear as like single boils or multiple abscesses. And then it can actually develop sinus tracts where it's basically like the boils are almost kind of like coalescing together. And then lots of
For anyone who's wondering what that word is, it's like they're connecting, but under the skin. It's like they're creating these tunnels through the tissue, which is as painful and uncomfortable as it sounds.
Yeah, so very, very painful, huge reduction in quality of life if it's not managed correctly, right? And lots of comorbid conditions too, like things that affect it are things like obesity, because there's a huge insulin signaling component to it, and PCOS too. Other things as well, like there's lots of comorbid anxiety, depression, other things like that. The way that I usually approach this is first I take a look at the area, obviously, make sure the diagnosis is correct, because it can be confused with folliculitis sometimes. But we figure out first what's making the HS better or worse. Is it like clothing, nutrition, any certain supplements, activities, things like that? And Sarah, we talked about this when we talked about acne, but in terms of why insulin plays a big role in HS is number one, insulin can be inflammatory when it gets too high, right? So in cases when people are insulin resistant and we're constantly stimulating that pathway. And the other thing as well that comes to play in that is signaling those androgen receptors as well, right? We have more sebum production, the production of boils and things like that. So basically that ends up being very painful for the person. The way that I managed this case, and I'll see him for a follow-up in a few weeks, but basically we did a lot of nutritional support. So kind of that Mediterranean sort of low insulin demand diet. We talked a lot about that. We also put him on a course of doxycycline, and in low doses, it can be anti-inflammatory and probably has some of the best evidence for reducing a HS flare. So basically 8 weeks of that. He also has Crohn's. So what we did as well.
I was going to say, I've never seen a case where there hasn't been some kind of autoimmune component, at least when it's bad. Like I have some people with very mild cases, but that autoimmune piece seems to be thick with HS.
Yes, exactly. It is well managed at this point, but we did do some gut support, and I just gave him a probiotic if he's going to be on the doxycycline anyways. And yeah, basically encouraged exercise as well, because as you know, I went to a dermatology conference recently, and they actually presented on the importance of exercise and HS, right? For the anti-inflammatory purposes and things like that. So that was a big component there. And a lot of the times with these patients, there's a huge mental health burden because number one, that they're in pain. Number two, that they're embarrassed, right? So one of the things that I like to do as well is make sure that they have hope in terms of like, hey, there is actually a treatment that can work well for you. And there's multiple steps that we can try. So that's a big one too, addressing the mental health component.
Yeah, I had a patient this week with PCOS. We were talking about it, and she had been diagnosed historically, not present. She's quite young, with a large boil, like bigger than a golf ball. And she was like, I feel like I can't, like she couldn't sit, she couldn't walk. And she was talking about how silly she felt that she was made to feel like it was almost like a zit, and she couldn't walk and she couldn't sit and she was in that much pain. And I was explaining to her that it's so much more than that. When you have something growing that's that large, it's displacing tissue, it's pressing on nerves. Like there's so much of that happening. And she was made to believe it was because of shaving or something like that, which is so commonly the source of misdiagnosis I find in practice, especially with new onset.
100%. Yeah. It's because a lot of people, again, like don't really know about this condition. So they say, oh, yeah, maybe it's like folliculitis and you were shaving wrong, which also I don't think is helpful because it puts the blame on the patient and makes them feel ashamed that they have this giant boil. And obviously it's clearly abnormal. You know what I mean? So if it was shaving, it would have been a very different presentation. So even taking a few moments to do a bigger history, like, hey, have you had anything like this before? Do you have any other boils like underarms, under breasts, things like that would have been more helpful in that case.
Yeah. So one of the things I see a lot with this condition is there's a lot of shame because of the areas, your arms and your groin and your buttocks, etc. And people are made to feel like they're dirty. I've had patients be told, don't sweat, don't exercise. Like it's you sweating so much is part of this issue, et cetera, et cetera. So how do you navigate that conversation in terms of like hygiene, topicals? Because obviously that's not where the research is, but that's oftentimes where people's head goes, right?
Yeah, it's definitely not a condition. Like if you have it, it's not that you're dirty or anything like that. It's an inflammatory condition of the hair follicle. Just like when people have acne, you can wash your face 4 times a day and still have acne, right? Again, that's very excessive, but that's just
like probably make it worse if it was my skin.
Exactly. That's the thing too, right? So with HS, in terms of topicals, you can do like a benzoyl peroxide wash for the anti-inflammatory and antimicrobial effects. Also chlorhexidine washes as well, about a 4% is helpful. And even if you are exercising, I love this, Sarah, hypochlorous acid before and after. It's amazing.
I was waiting for it. I was like, it's coming. It's coming. Aiden has eczema, my youngest. And so when it's like not open and just starting, I'll like chase him around the house with the hypochlorous acid spray. And I'm like, if he ever meets you, he's going to be like, absolutely not. This one got me chased around.
It's amazing. It's antimicrobial. It helps heal. Like it's soothing as well. So lots of things you can do from that regard, but definitely like taking a step back from that shame aspect. And obviously hygiene's important, but a lot of the times, like if you shame someone for that or even have that conversation in terms of like, yeah, shower more, do this, don't exercise. Yeah. And I just mentioned earlier that exercise actually helps reduce sort of the HS flares and things like that. So very counterproductive if you bring that into your conversation.
And even just how you ask those questions, like this was years ago, I had a patient and one of the first questions the doctor asked, she had her third boil in her groin, was, does it happen every time you have sex? And instantaneously, even though the doctor wasn't indicating anything, their assumption was this is because I'm having intercourse.
Yeah.
Right. So as doctors, I think sometimes we don't even think about the impact of the questions we ask in the order, right? And just saying, hey, this isn't often involved, but is there any relationship to intercourse? You know what I mean? Have you been tested, etc.? Not that that's a relevant question in this case, but still, I think it's those types of things. If you're a patient and you're holding on to some kind of belief structure because of a question someone asked you, make sure you ask someone else about it. I was very grateful that this patient was like, this feels like a really awkward question. But one time the doctor asked me if it was because of sex. Like, is sex causing this? Because I'm almost afraid to have sex now. And I was like, absolutely not. Thank you for asking. Let's navigate this, et cetera, et cetera. So I think that's just a good tip for any patients out there feeling.
Exactly. It creates that fear and association. You can use anything as an example for that as well. For someone saying, oh, is it happening every time you exercise too? That person's going to be afraid of exercising. And then even maybe creating this self-fulfilling prophecy where they say, yes, anytime I exercise, I am going to have a flare. And honestly, we underestimate how much our mind can impact our body a lot of the time, especially with skin conditions.
Yeah, absolutely.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada, But don't worry, if you're in another province, still reach out, get added to the waitlist as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
Okay, Laura, what have you been up to over there in Ancaster?
All right. Well, lots of thyroid, which I know is an ongoing joke between us. I definitely attract a lot of that, but I love treating thyroid health. So, my case is a particular patient who was diagnosed with hypothyroidism about 3 years ago and has been medicated with Synthroid ever since and still feels unwell. And in fact, she feels worse. So she's really seeking care to really get to the root cause of what's going on and just look for alternative forms of care. Her main symptoms were struggles losing weight, there was constipation. She had a lot of widespread body pain and joint pain. Her main symptom, though, was fatigue. She said, I used to be this really outgoing person, very social, no struggles at all with energy. And now she was struggling to get to work. She was finding she couldn't even leave the house to go visit family and friends. Like, she had nothing in her. Libido was extremely low. She was now experiencing brain fog. All to say, there was a lot happening for this patient. She also had hair loss. So with her, it was really about validating her symptoms, right? And really trying to educate her and explain all the other factors that could be contributing to her symptoms and the extra investigations that we wanted to do. And even one of my first questions to the patient was, do you know if you ever had your thyroid antibodies tested? And she said, no, that doesn't really ring a bell. Like, I imagine if I did, they were normal because my doctor never said anything. So in terms of her labs, we looked at a lot. We didn't just look at thyroid, although the antibodies I was very concerned about, I would say, and wanted to see, but we looked at insulin, we looked at inflammatory markers, we looked at nutrient status, because all of those things can also impact your symptoms, right? Whether it was the hair loss or the joint pain, the constipation, and then the weight gain. And lo and behold, this patient's thyroid antibodies came back almost in the thousands. So
Let's break that down for a minute, because I think it's such an important conversation. So there's two big things that you said there that I think are so critical. One is patient given Synthroid told they should feel normal and don't. So I want to break that down. But then the other piece is, what is an antibody, right? And I see this all with naturopaths are known because we read thyroid labs different. Like, I had a patient this week, half of her thyroid was removed. And she was coming in because she was told her labs were normal. And she's like, I don't know if they're normal or not, but like, I want a different perspective on if this is normal, right? So when we start with the antibody piece first, what does that mean? When you have a patient in front of you and you're asking them, have you had your antibodies tested? And they're like, what is an antibody? How do you describe it?
Yeah, good question. So I describe it as essentially what an antibody is it's a protein that is produced by the immune system that mistakenly attacks the body's own tissues. So in this case, it was the thyroid gland. And then the two antibodies that I was particularly looking at, I didn't say this to her because they're a mouthful, but it was the anti-thyroid globulin and then the thyroperoxidase antibody. So those are the two that we look at if we are investigating for Hashimoto's, which is the autoimmune cause of hypothyroidism. And so really, I think for a patient to even just hear that, it's so validating. Not only are there more tests that we can do that can help me understand why I feel so lousy, but it's also just educating the patient too about their body and what kind of responses our bodies can mount sometimes, and especially how deeply connected our immune system and inflammation are in almost every symptom we can sometimes experience.
Absolutely. And I always really like to qualify this for patients because they'll say, why hasn't this been tested? And the reality is, antibodies are literally just a way for science, the medical community, etc., to be able to identify if a specific tissue is being addressed by your immune system. So we have a very limited number of blood tests for thousands of potential compounds in the body. So when we're looking at these immune responses, it's like 80% or so of people with hypothyroidism, so poor thyroid function, have an autoimmune attack, meaning there's been so much damage to their thyroid that their thyroid can't produce enough hormones. And then their brain starts to yell to say, we need more help. And the body can't make it because the hormone producing tissue is gone. And when we look at that, people will say, well, why wasn't this investigated further? And the reality is, there is not a single pharmaceutical drug that has been shown to lower thyroid antibodies consistently and repetitively. And yes, people will say, well, there's LDN, there's prednisone, there's, okay, fine. But a lot of those things are not consistent, predictable, and don't necessarily change outcomes. And so if doctors are in that situation where they don't have a treatment option, why would they do the test?
Yeah.
Right. So that they can get you alarmed seeing this antibody that should be less than 20 in the thousands. And then you are nervous, you're Googling it, you find out that that means you could develop another autoimmune condition in 5 years and another one. Of course, they're not going to do that. That's just good medicine. The challenge is that they're not referring, or they're saying, you're on Synthroid, you should be fine. All these other symptoms require a mental health medication, or maybe you should see a rheumatologist, or maybe you should go for a sleep study. All of these things are great things, but it kind of misses point in a lot of situations that there's so much research on how to lower thyroid antibodies. It just so happens to be that it's all in our world. It's not
Yeah.
in theirs, right? So
Yeah.
as a patient, if you've ever felt frustrated by that system, I want to honor that. But I also want to acknowledge on the other side of the coin that it's often because there's not something they can do about it. And so it is about empowering yourself to ask better questions of the providers who can help you and who can make a difference.
Yeah, absolutely. And that's such a good point about if they can't treat it, they're not going to test it. And that's not wrong by any means, but that's where we can really help fill that gap, I think, in medicine and help support patients who they're not feeling better and they're on a medication that should be improving their symptoms. And I think, too, helping a patient even just give them answers is extremely validating. Like, this poor patient has been feeling not herself for years. And to be able to have that conversation with her about this is why, and then this is what we're going to do, had her nearly in tears, which even that was therapeutic in itself. So,
Yeah, absolutely. So Synthroid, for anyone who doesn't know, Synthroid is a T4 based medication. So it's a medication that is just providing one of the hormones. Okay. When the thyroid makes hormones, it makes T3 and T4. So it makes a lot of T4, which is the storage hormone. It makes a bit of T3, and then it makes a teeny amount of T1 and T2. Okay? And all of the numbers stand for iodine. So it's literally just like the size of the compound, how active it is, and where it's working in the. But there's different types of medication. So there's just T4 in a medication, so purified T4. There's purified T3 in a medication. And then there's medications called desiccated thyroid. So there's NDT is what you'll often hear it called, natural desiccated thyroid. In the US, it's like Armour thyroid. Here we use IRFA, or again, just like a general desiccated thyroid brand. But one of the things that's very important is for a lot of people, just taking the storage form of T4 isn't necessarily fully solving symptoms. So what are some of the issues and some of the reasons why you see that come up?
yeah, and usually it's a matter of their body is not converting T4 to T3 the way we want it to. And our body, what it actually utilizes is T3. So for us to see benefit in terms of improving hypothyroidism related symptoms, whether that's the fatigue, the constipation, the hair loss, whatever it might be for that person, we need a adequate amount of T3, not just T4. And so this is why sometimes too, I've had patients who they don't notice any change on Synthroid, but then if they're switched to desiccated thyroid, they do start to symptomatically notice change. And it's because we're giving the body both T4 and T3.
And there's actually a lot of research on that, like quality of life metrics improving when someone's on T4 and T3. So,
Yeah, absolutely.
And what are some of those conversion factors? You mentioned them already in terms of what you tested, but what are some of the other things that patients could ask for testing around, come to understand when it comes to that T4, T3 connection?
Yeah, so I think one of the biggest ones that I look at is insulin resistance. So we see a lot of overlapping symptoms between hypothyroidism and insulin resistance as it relates to fatigue, brain fog. We can see hair loss with both. We can see weight loss resistance with both. Those are two really closely connected ones. So the 2-hour insulin glucose challenge is our favorite test here at Advanced Women's Health that gives us so much clinical insight into what's happening with someone's blood sugar and insulin regulation that I almost always run if I'm suspecting a hypothyroid picture or an insulin dysregulation of sorts. I also look at inflammation and gut health, right? And how closely those are tied to brain fog. And we're going to have maybe sluggish digestion there too, and constipation. We can see hair loss with that as well if our body's now not absorbing the nutrients that we need. And then that kind of leads me to my next point, nutrient status. So I really like to look at iron, vitamin D, and vitamin B12 in particular as it relates to some of those other symptoms that patients can present with: dry skin, brittle nails, hair loss, fatigue, troubles concentrating. Those are all some important factors that I like to look at too.
Yeah. And I think the moral of the story here is so often people are just desperate to get a diagnosis because that's the thing that validates them. So I'm not saying this patient felt this way, but I can tell you I've had hundreds of patients who have. They finally get a diagnosis of hypothyroidism. They're exhausted, falling asleep, their hair's falling out, they're gaining weight, they're constipated, etc. They go in, they finally, that TSH ticks over the high mark, it's folded. They're like, you know what I mean? They're like,
Yeah.
yes, I'm finally going to feel better. And then they go to their doctor, they get the triumphant prescription, right? And they take it. And they're like,
Yeah.
nothing. And at that moment of like just validation and elation, often bottoms them out so hard because they don't feel better and they think it is them and they're eternally broken and they're hopeless. And one of the things that I always say is that may be the start of your journey, but it's definitely not the end. Even if
Yeah.
someone takes Synthroid and feels better, if you have an autoimmune thyroid condition, your dosage is going to go up and up and up and up every couple of years. That is
Yeah.
just as more damage occurs, you are going to be at risk of other inflammatory events, etc. But
Yeah.
if you don't feel better, there's so many options. We can address inflammation. We can address the gut microbiome, the liver. We didn't even get into that, but that's such a huge piece of
Mhm.
thyroid function. Blood sugar and insulin, which plays into the liver, iron. Even again, like people ask me a lot about iodine status. I'm not going to talk about that here. We are an iodine sufficient nation. We don't need to get into that in a big way today. But all of these conversations are one that we have in our offices every day. And I think it's so important that people get to kind of hear behind the scenes of what's going on there.
Yeah, absolutely. And one other piece there too, in terms of Hashimoto's in particular, an important question that I even asked this patient was, what's your viral history? And that was really interesting how it was also similar timeline to when the patient had COVID. And
Mhm.
it's just interesting to learn about how the body is affected in so many different ways, right? Whether it is like we're talking about liver function, insulin, gut health, or immune health and viral history, I think are all so important in looking at a case holistically.
Yeah. Love it. Very good.
Mhm.
Well, on that note, anything else that you wanted to dive into? Because I feel like people got a lot of different perspectives today.
I know. I mean, the COVID piece was interesting to me. Have you still been seeing that show up lately in practice? Just even whether it's long COVID or whether it's
Yeah.
connection with any autoimmunity?
Yeah. Yeah. So one of the things that we have seen a lot is this new onset diagnosis of Graves. And I like internally twitch as I say this. So when we talk about Graves disease, it's the opposite end. So we have hypothyroidism, which means your thyroid's not making enough hormone. Your brain is screaming at your thyroid to work, and it's not for whatever reason, the most common being autoimmune. The other side of the coin is what we call thyroiditis, hyperthyroidism. Okay. And that is where someone has their thyroid making too much hormone for some reason. And so they have oftentimes opposite symptoms: anxiety, insomnia, loose bowels. Like it goes, heart palpitations, it goes in the other direction. And the most common cause of that is Graves. So it's an autoimmune condition where there's an antibody that causes your thyroid to push out hormones. We keep getting patients. And I would say it has calmed down in the last 6 months or so, but for a couple of years there, it was rampant, where they're coming in and they're saying, "Do you treat Graves' disease?" And I was like, "We do, but you probably don't have it." And so what was happening is patients were having their thyroid affected by COVID. So we know that COVID could enter the thyroid, and then they got what we call post-viral thyroiditis, meaning there's a lot of damage and inflammation. And so your thyroid, I used the water balloon example, but your thyroid's like a whole bunch of water balloons stuck together. The hormone is made on the outside of the water balloon and stored on the inside. And so the virus is damaging the water balloons and they're blowing up and the hormones are just coming into the system. And so the brain is like, I don't need any more hormone. But if you measure the autoimmune response, you measure the antibodies, they're not there. So it's not that your immune system is telling and forcing your thyroid to push out more hormone. It's that there's damage to your thyroid that is making you spill hormone into the system. And so that was something we were seeing a ton. Again, it's been a bit better in the last 6 months. But if you're given a medication to suppress that, if you are marched down that road because they don't realize, and I was talking to an endocrinologist a couple weeks ago, and she was like, I didn't realize that thyroiditis could last that long. I thought it was like a week or two. But when you look at some of the newer research and realize that just like people have longer symptoms post-COVID, we're getting longer of every symptom post-COVID. That doesn't mean it's Graves' disease. We have to test those antibodies. So we had so many patients come in and we test the antibodies and they were negative. And we're like, okay, perfect. You don't have Graves, but here's what we do need to do. And it was a really empowering conversation.
Yeah. Wow. That's so interesting. And I'm learning from you too on this podcast. It's fascinating. And I think that ultimately comes down to kind of the root of what we're talking about today, right? Is getting to the true cause of what's happening in someone's body, whether that's through labs, whether that's through actually having the time to talk about all the symptoms that they're experiencing. I think it's really empowering for a patient.
Yeah. And I'm also going to just like put a plug here. I can say things like, we had so many patients, we've seen all of these trends, because we see thousands of patients a month at this point. And so if you are in a situation where you have a doc that you love, whether that's a naturopathic doctor, a chiropractor, a physio, whatever, you know what I mean? Like a medical doctor, it doesn't have to be any specific designation. And you feel like there's something going on and they don't see it. A lot of people didn't know that there was an upregulation of thyroiditis post-COVID. A lot of people didn't see the volume of things. And so they're not digging into their research, trying to figure out what's going on, and then being able to communicate it in lunchtime calls like we get to. So it doesn't mean anyone's wrong. It's just we all have limits to our knowledge. I'm included in that. You know, you throw me a prostate and I'm like, I'll figure it out, but like it's gonna take me a minute, right?
We'll be here all day.
I know, right? Like we all have limits to our knowledge, and I think the more you work with people who are in groups that focus on excellence, the limits of their knowledge just are pushed so much further because there's so many people contributing. So we all learn from each other.
Yeah, absolutely. And I think it's so helpful having those clinical calls, because if I'm not seeing something very often in practice, well, then you probably are, or someone else is. And then when that patient inevitably maybe walks into my room one day, I'll be better equipped to help support them.
Absolutely. Absolutely. Well, thank you, Laura, for coming on. I know everyone gets nervous when I come up with these new podcasts and ideas. I really love to stretch my team out of their comfort zone, but I hope it was helpful, everyone. If you loved this podcast style, I would love to hear your feedback. We're going to do a few more iterations, but I do think it's a lot of fun to hear what we're treating and how we're navigating it. And thank you to Dasha, who had to jump off into patient care.
Yes, this was so much fun. Thanks, Sarah, for having me.
All right. Thank you, everyone. And we'll see you next week.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.